will deliver my best and justice will be delivered. I don't have any financial disclosure. So ICU hyperglycemia, perhaps every one of us as a clinician or diabetologist must have faced, but there are certain rules which we have to keep in mind. I think in these 10 minutes, we keep these every time when we visit the ICU. Now, let's understand why ICU hyperglycemia demands our attention. The reason being that in ICU setting, the critical ill patients, they transit through lot of fluctuations in their hemodynamic parameters. Lot of medications are going on. There would be hypoperfusion at the tissue levels as well as the kidney level. They might be going through multidisciplinary issues. The issues over here will affect both patients and diabetes and outcome prior to the glucose monitoring. A lot of things might have happened. The routine expectations of the response of the insulin may not work here. You have to be very, very vigilant. You will be always on your toes because you cannot allow hyper or hypo either of the way for the patient because they are fragile. Stress-induced hyperglycemia is also one of the reasons. Previous speaker also stated I have one case for that also. And early recognition and combined with proper management strategies can save a lot of lives. Hence, this is very important for us to understand the basic fundamentals. Now, before I move to this slide, please try to understand that the only thing which is approved right now for the critical ill patients, hemodynamically unstable patients in the ICU setup is IV insulin. So please remember, diabetes, critically ill in ICU, always I for ICU, I for insulin, I for IV. If you remember these motto, you will never be in a wrong place for your management. What ADA 2025 have said for the management of ICU hyperglycemia, that your threshold for initiation is more than 180. So anything above 180 in your ICU critical ill patient, you should be treating it. Secondly, hypoglycemia prevention is utmost important because imagine a patient with myocardial infarction. You give hypoglycemia, post-plasty or post-CABG. God knows what can happen to that patient. Target range, please remember, keep it in your mind, 140 to 180 is the target. If you know the target, you will chase it in a proper way. So whatever regime you are using, as per your protocol, written protocol in the ICU, you have to order your nursing staff, your medical officers that my target for this critical patient is 140 by 180. We may change in one condition, we will come to know. And baseline assessment is very important. If HbA1c is possible to access, you have to have previous medication history, whether recent SGLT2 inhibitor was used or not. I had one euglycemic ketoacidosis patient who was managed as diabetic ketoacidosis, but actually sugars was in the range of 100-125 only, and there was severe metabolic acidosis. Those were the initial days where patient had gone on SGLT2 euglycemic ketoacidosis. RSSDI since long have been saying that over and above what AD has endorsed, what RSSDI says, you have to stratify the risk management for the patient, and hence you have to you have to individualize the treatment. You cannot keep the CKD patients of critically ill patient, a goal which you are setting for the patients of neurological disorders. Monitoring frequency has to be also individualized, right? You have to, more frequently you know the patient's sugar, more frequently you will be able to intervene and you can manage the sugars. And transition planning also has to be kept in mind, as we do in type 1 diabetic patients who are suffering from decay and recovering. We give the shot at least 1 hour before, sub-Q shot, when patient has recovered from the decay, and you want to start with the sub-Q insulin from the IV. You do not stop IV directly and start with the sub-Q. You at least give 1 hour prior sub-Q dose, and then gradual over a period of 1 hour, you stop the IV. So keep everything planning before, during, monitoring, and after, along with the ADA recommendations. That's what RSSDI also say. Now, quickly, I'm coming to the 3 simple cases, but the message is bigger. This is first case of post-myocardial infarction without diabetes. Now, how can we discuss a diabetes conference in a diabetic conference, a non-diabetic patient? But stress hyperglycemia is something which is known to everybody. This gentleman had blood sugar of 260 and HbA1c of 5.8, had suffered bad myocardial infarction, had gone for LAD-plasty, and had arrhythmia also. So what you have to do is that, yes, stress hyperglycemia has to be treated for with the IV insulin till the patient is not recovered, because hyperglycemia also harms the patient and it is pro-arrhythmogenic thing. You need to control the myocardial injury, you need to control the endothelial dysfunction at the plastic place, and you have to also make sure that you don't never end up with the hypoglycemia for these vulnerable patients. And obviously, when you stabilize the sugar within 4 or 5 days, when patient is stabilized, sugars will also go away and the insulin requirement will also go away. This patient will go home without any OHA, just to have a message that you frequently check your HbA1c. You may end up with the diabetes in upcoming years. This is what Dr. Pratap Jethwani sir said, that you have an ICU patient in septic shock. How will you manage these patients for diabetes management? In fact, for example, a patient of pneumonia going for septic shock on oxygenation and hypotension, would you agree that you will go for subcutaneous insulin? No way. Would you agree that patient should be continuing their routine OHS? There is no way. So the best and safest alternative is you go for the IV insulin. Say for example, you have a regular insulin, you go for 50 cc normal saline and 50 units of regular insulin. You start infusion as per the recommended by RSSDI rate, and you frequently evaluate these patients every 1 hour, 2 hour, 3 hourly as per the recommendations and the stabilization of the patient. So this lady had septic shock, hypotension, started with the IV insulin, and her glucose was so variable that suddenly it shoot up from 90 to 300. Right? So you have to be very careful. You can go for even 1 hourly monitoring for this patient initially. Once you realize that sugars have stabilized, then you can go for the 2 hourly or 3 hourly monitoring. And obviously when patient is treated with the appropriate antibiotic, and gradually when patient stabilizes, you can shift her to the basal bolus regimen, sub-Q when blood pressure is good. And at the time of discharge, you may shift her to the routine OHS as per the tailor-made. And third case perhaps has been discussed by the previous speaker, but please remember, any CKD patient getting hospitalized, you have to remember that patient, I will just complete in 1 minute. You have to keep in mind that this patient might be going for dialysis perhaps every day, because critically ill patients CKD would require dialysis perhaps every day. That would be acute and chronic kidney injury. So make sure that pre-dialysis, you, if possible, if there is hypoglycemia, change your regime from supportive IV fluid if needed. You can go for even dextrose normal saline to prevent hypoglycemia if sugar is reaching up to 70. And in this only case where your blood target is not 110 to 180, you may keep the targets higher in the ICU of 140 to 200 also, because one hypoglycemia to a bad CKD patient can catastrophically jeopardize the life of the patient. So there are certain practical challenges. The staff training is important. Please make sure that don't go for routine subcutaneous sliding scale that is discouraged by RSSDI at multiple times on platform. There are evidences and standardized protocol which I have already discussed. The only 3 key messages which I go for is AD and RSSDI already clearly endorsed that IV insulin for the ICU critical ill patients is the only option. You don't have other option. Secondly, case-based learning is important and you have to individualize the case. And thirdly, systemic implementation of standardized protocol in the ICU where you visit and staff training is extremely important. Thank you so much.